Sounds good. Thank you, Dr. Hanover, for setting a good stage for us. So I'm Faisal Aziz. I'm a vascular surgeon, and I love health sciences outcomes research, and that's why we're going to talk today. I'll be brief, and Justin Pitucci from Dr. Hanover's lab is going to talk after me. But before I start my presentation, if there's any takeaway from this would be two things, if you can remember. One is that electronic health records, as Dr. Hanover mentioned, is a powerful tool. Unfortunately, we have to understand that electronic health records were not designed to do research. When electronic health records were made, they were designed for billing purposes. Frankly speaking, it does a very good job in billing. So therefore, many years down the road, we're struggling to find, good data, which can do good research. And we are getting better, don't get me wrong, but the intent of electronic health record was always billing. One. And second thing, if you want to take away from my presentation, would be that I think so far our statistical analysis have been very good in determining the associations. Our struggle as researchers is always to come up with predictive models which we can come up with a reasonable explanation to develop some cause and effect relationship. Being said that, these are my disclosures. So, as I said before, the topic of my presentation is to go over electronic medical records. Why are we going to talk? Why is it important in this day and age? And number two, why did we choose to explore the area of readmissions to the hospitals and use this tool to discover that? And how did they interact with each other? Now, going back in time a little bit, not long time ago, just 15, 20 years ago, that's how medical records for patients to look like. That's how when I was a medical student, when I was an intern resident, that's how charts look like. Each chart was handwritten and there were multiple issues. So imagine going back, for many audience in this who had done any research project, 2 decades ago. Research meant looking at patients' data when going to an office with charts full like this, and you have to pull up each of these charts and to figure out the patient's detail with doctors' handwritings, which most of the times look like EKGs, to figure out how do you collect the data from this. So this is where we come from. So 2009, U.S. Congress basically had American Recovery and Reinvestment Act. And as a part of that act, it mandated electronic medical records for health systems. And the perceived, benefits or the convincing points was, number one, to have centralization of patients' clinical information, especially for larger university hospitals, to have one centralized hub where anybody can go to and look at the patient's medical records. And from a physician and provider standpoint, it made life a whole lot easy. I remember the days when we have to bring the x-rays yourself, grab from x-ray department and bring it somewhere. But now we can look at the labs and the PAC system and the pathology specimens all in one centralized, place. And for patient safety, it reduces medical errors, the drug interactions, the wrong doses, it catches up pretty damn good. But let's not forget the fact that this was all done with the intent of having accurate billing and coding. And that's why health systems across the country have very heavily invested in the electronic health records for financial reasons. Now, interestingly, when electronic medical records were implemented from a physician standpoint, it has been shown in multiple studies. We actually have done some studies here in our institution that the time spent on electronic medical records is actually higher as compared to paper charts. Physicians spend more time, unfortunately, sometimes documenting more than actually direct patient care. And many of the physicians have shown multiple times that the clinical computer work is the highest proportion of the time. So that's where we offer electronic medical records. Now, coming to the topic of why we thought readmission is a good area to explore is, once again, going back in the history, since 1980s, there's a PPS system. It was used for hospital payment systems. However, in early 90s, there was, the insurance companies realized that patients were spending a lot of time in the hospital. So there was a lot of push to reduce the length of stay. So the health systems and the hospitals were incentivized in 1990s to reduce the length of stay. And guess what? It worked. There was, in that 10-year time period, there was a 25% reduction in length of stay. Unfortunately, what nobody saw at that time coming was that at the same time, there was similarly increase in the risk of readmissions, suggesting that when patients were likely, in order to reduce the length of stay, patients were discharged earlier, and hence the readmissions occurred. So, there was a significant increase. And then in 2009, CMS started to publish data about the 30-day readmissions as well. When Affordable Care Act became the law in 2010, one of the sections of the law basically, suggested that hospitals should be held responsible for readmission within 30 days. Now, Agency for Healthcare also deems now length of stay to be a parameter for billing purposes and the quality of care. And now they also consider 30-day readmission to hospital also as an indicative of the quality of care provided at the index hospitalization. Now, from patient standpoint, it has been shown in multiple studies that any readmission to hospital has a negative impact on patients' quality of life. Patients return to work in a delayed fashion. If there are readmissions, there's a delay in return to work. And frankly, in this day and age, when we have health systems full of patients all the times, when we need beds, there is incentive in the health system to reduce the risk of readmissions. When we look at the surgical, if we look at the medical readmissions in general, most common reason for readmission after a medical discharge is actually primary diagnosis. And most common reason for readmission after a surgical discharge is actually post-operative complications. So the most common surgical procedures, for all comers associated with readmissions are leg amputations, colorectal and peripheral vascular disease. Me being a vascular surgeon, having number 1 and 3, which affects our part of life a lot, that's why we chose to look at the readmissions. So about 10 years ago, our group started to look at the readmissions. As Dr. Hanover rightly pointed out, that electronic medical records have lots of power. And, we're very fortunate to work at Penn State, in which we have access to many databases. So the examples which I'm going to show you quickly are from American College of Surgeons National Surgical Quality Improvement Program, which we are a part of. And what it does is basically collects the surgical data from nearly all hospitals across the U.S. and piles them together. So this was our paper from 7 years ago. So in year 2013, we looked at all across U.S. We looked at the NSQIP database, and we specifically focused on the patients who were undergoing peripheral arterial bypass surgery. Coming to Dr. Hanover's point, had we looked at our institution only, we would have about close to 300 patients. But now with the power of EHR from across the country, we had a much larger sample size, about 2,500 patients that we could actually analyze. And we looked at multiple factors, and we divide the patients into, no readmission group and readmission group, and did multiple analysis to look at what are the factors which are identifiable. And we also identified that about 50% of the readmissions happened within 2 weeks after the hospital discharge, and that's where the focus needs to go. I can also tell you that after these papers, we actually were able to recruit 3 vascular nurses now, who actually give patients a phone call a day after discharge and within a week after discharge. And we have shown that with those phone calls and checking up on the patients and making sure that they're getting appropriate amount of medications and any surgical complications before it happens, we have actually reduced the risk of readmission. And that would have not been possible had we not been able to show such a powerful data showing that the readmissions are preventable. Now, we identified in this study that the most common reasons for most common factors associated with readmissions were wound infection and reoperation. Once again, we cannot determine cause and effect relationship, but there's a very strong association of postoperative wound infections and need for reoperations. And as I pointed out before, the purpose of the medical records is actually billing purposes, less so for research purposes. So it's disappointing to see that about 41% of the patient we could not determine as to why the readmission occurred. But for those in which we could determine the reason, we identified the reason it was associated. Also, I think with statistical analysis, we were able to identify the risk factors which are associated with readmission and come up with a probability of readmission. And we identified 7 or 8 factors here that each factor in itself was causing the increase in the risk of readmission by a certain percent. But if we added all these risk factors together, the predictability model increased to 98% accuracy. So after this data, and 2 years later, we embarked on another intervention for peripheral arterial disease, knowing the fact that most patients with peripheral arterial disease are now undergoing lower extremity endovascular interventions. So we decided to look at the endovascular intervention. Once again, we looked at the NSQIP data. We had about 1,100 patients, and we specifically looked at the same year as we had the bypass data to make sure that it's the same time periods and there's not much change in terms of medical care or other issues. When we look at the univariate analysis, you can see that we identified multiple risk factors. For example, people with critical limb ischemia, i.e. rest pain or tissue loss, had a high risk of readmission as compared to other. When we, once again, I think it identified that the highest time for readmission to the hospital after intervention was actually within first 2 weeks. It sort of solidified our experience with the surgical bypasses as well. And as I mentioned before, getting vascular nurses dedicated to do that actually showed clinical benefit for us. When we look at the multivariable analysis, you can see that there are multiple factors which are associated with readmission. And once again, majority of the patients we could not identify in the National Electronic Health Records what was the reason for readmission, and that's the sad part. However, we were able to identify the factors which were associated with the increased probability of readmissions, and as just like the previous study, we had multiple individual factors which were increasing the risk of readmission. For example, unplanned return to the operating room for any patient increased the probability of readmission to about 43% in itself. So that was the biggest marker. But if we add all these factors together, the risk increased to about 97%. So I think what we have shown, we have a few other papers on similar topic, is that we have shown that unplanned return to the operating room and the race of a patient is associated with the readmissions. So I think, as Dr. Hanover pointed out, one of the advantages of outcomes-based research is that we can actually branch out to multiple institutions across the country, and for trying to access database across the globe to have a much large sample size to reach conclusions which are statistically significant. And future direction, Justin Pettucci is going to talk in a minute about what he and Dr. Hanover's lab is doing. I think the next step for us is to come up with predictive modeling and see how can we use machine learning for that purpose. So I'll hand over to Justin Pettucci, and I'm very thankful to our postdoc fellow Hassan, and I think between Hassan and Justin, it's a good collaboration between Penn State Hershey and Dr. Hanover's lab, and we look forward to seeing the results. I thank you all for your attention.